Thousands of us who die of cancer every year could be saved if British cancer diagnosis and screening were up to the standard of comparable countries around the world. Yet the National Health Service's bowel cancer screening is second-rate, compared even to what's available to people in one of the poorest neighbourhoods in America.
We're still having far too many people being diagnosed late, and that invariably means that those individuals won't survive.
This is the reality of terminal cancer.
Right now I don't feel very alive. I feel more in the face of death, but we'll see what today brings.
Everything can change within 3 months. You know, I could be dead in 3 months' time.
We are not putting the resources that we need to put in, should have been putting in for the last 20 years, into early detection and screening.
For years, politicians and health service bosses have talked about the importance of early cancer diagnosis and doing something about it. In 2000, the government launched the NHS Cancer Plan.
The biggest ever programme to replace and update equipment for screening, diagnosis and treatment has begun.
In 2007, the government said,
"The earlier a cancer can be diagnosed, the greater the chance of a cure."
In 2010, David Cameron picked up the theme.
Today we're announcing that actually we're going to be spending another £164 million on cancer provision and really updating and improving our screening processes, particularly on...
But Britain has a history of poor cancer survival rates compared with Spain and Italy, to say nothing of the United States, Australia and Canada.
What we're really seeing here still is a lack of political will to actually put your money where your mouth is. If you get diagnosed early and you get treated early, your chances of survival are nearly 90%. But if the cancer is diagnosed too late, if it's spread around the body, invariably you're going to die of that cancer.
Got my test result letter today. It says my result is normal.
Oh, and they gave me this leaflet about breast awareness.
NHS programmes that regularly screen women for breast and cervical cancer are proving effective. But 3 other big cancers, bowel, prostate and lung cancer, kill almost 60,000 people in Britain every year. That's almost 40% of our cancer deaths, the equivalent of 1 every 9 minutes. Our early diagnosis and screening programmes are failing thousands of these men and women every year whose cancers are found too late to save their lives. This is the Allens. They live in Stevenage.
Hi, I'm Gail Allen. I'm 53 years of age and I was discovered with terminal bowel cancer last July when I was 52.
I'm Fred Allen. I'm 68 years of age and I was diagnosed with prostate cancer in 2011, which has metastasised into incurable prostate cancer.
Gail didn't qualify for the NHS National Bowel Cancer Screening Programme because it's only for the over 60s.
I was never screened for a cancer. Either it was irritable bowel symptom or there was something wrong with the uterus or the fallopian tubes.
Gail had lots of pain and other symptoms. She made at least 9 visits to her doctors and the hospital before she was finally diagnosed.
So it was found that I'd got terminal bowel cancer that had spread to the liver and the lungs, and it was so far gone that it was too late for any form of surgery.
Fred's also missed out. There's no prostate cancer screening programme in Britain, even though it kills 10,000 men a year. All the NHS offers men is to ask their GPs to refer them for a cheap and simple blood test for prostate-specific antigen, or PSA. In turn, GPs are instructed to explain the pros and cons of it, which can lead men to forego the test and not ask for it again.
As I went to my GP, I also have a PSA test for prostate cancer, and he poo-pooed the idea, really, saying that It was slightly flippant, saying it can cause more problems psychologically than can cure. He talked me out of having a PSA test. I just forgot about it, really.
That was in 2002. 2 years ago, Fred's PSA was measured while he was having other blood tests. The result was high and he was examined.
The guy there said that the prostate itself was like a walnut. It was solid, small and hard, which it shouldn't be. I didn't really take that on board. My wife did at the time, started crying. Then I realised what he was saying. I've got prostate cancer.
Prostate cancer is as big a killer of men as breast cancer is of women. And the PSA test isn't perfect. It can indicate you may have cancer when you don't. On the other hand, in part of Austria, where the policy is to give all older men a PSA test, prostate cancer deaths have fallen 54%, compared with a 29% fall across the country. Gordon McVie was Chief Executive of Cancer Research UK and has been a practicing oncologist for 40 years.
I think we need a screening program because that does bring men into the system and it gives them contact with the issues around prostate cancer. And there are lots of issues for men to grasp around the area of prostate cancer. Most men do not know where the prostate is.
But a national PSA screening programme for older men isn't going to happen. NHS policy is explicit.
A systematic population screening programme is not recommended.
It says PSA is a poor test. It's difficult to distinguish between fast and slow-growing cancers and more data is needed. But that's little solace to the men who die of the disease. Because prostate cancer is not just a killer, it's a painful killer. This is the Roxbury neighbourhood in Boston, Massachusetts. Many American men routinely have PSA tests as part of their private health plans. But here, many don't have private insurance, and the US government won't pay for PSA tests. So Harvard Medical School runs a free mobile PSA clinic. The doctor in charge is Jacques Carter.
If you don't have a PSA test or some similar test to screen for prostate cancer, men are going to present the way they did 30 years ago when you didn't have the PSA test. That they're going to present with back pain and leg pain and broken bones because they have now stage 4 metastatic prostate cancer. And that's an unfortunate thing because if that guy has an aggressive tumor, he's certainly going to be dead in a few years. And it's going to be a horrible death because they have a lot of pain. So we want to pick those men up before they get to that stage.
Okay.
Yes,
all right.
That's all right.
The flip side, by certain critics of screening, is that, well, you know, you have these guys and you operate on them and they either will have some issue with impotence or maybe some urinary tract problem or they're going to be dead in 5 years. I'm willing to bet that 95% will choose the side effects rather than death.
Henry Howell is one of Jacques Carter's patients.
My brother, he was diagnosed with prostate cancer at almost 43 years old. I was diagnosed a year and a half later.
Henry's treatment has been successful. His brother's wasn't.
My brother, he said that he wished he could have got the diagnosis I got. How would you feel if somebody told you your cancer is spreading and you'll live 5 years if you're lucky? He got to the point where he couldn't walk. He was in tremendous pain, you know. It was a terrible way to see somebody die. The PSA test is just a sample of blood. It's a simple test to prevent so much pain and suffering. I'll say to any man, anywhere, if cancer runs in your family, start getting screened early.
Afro-Caribbean guys have a greater incidence of prostate cancer than white guys. And the mortality is nearly 2.5 times the white rate. But I'm talking about white men who have family histories. They're at high risk too. They ought to get screened by 50 for sure, but certainly if they're interested, I'll screen them in their 40s.
But as in the United States, there is no programme for men at high risk in England. This is London's East End. Prostate cancer death rates are abnormally high here. A couple of years ago, the first independently evaluated drop-in clinic in England was set up offering free PSA tests. It took 2 years to find the money.
Although the Department of Health, and in particular the Prostate Cancer Advisory Group, supported this effort and supported this venture, there wasn't actually any money forthcoming from them. So I had to persuade Newham PCT to stump up most of the funds for this. Wasn't quite enough, so I approached what was the Prostate Cancer Charity to make up the balance. At first, we tried to engage the men in a discussion about the pros and the cons, and how PSA is by no means a perfect blood test, by any means. But it quickly became apparent that actually they wanted to have this PSA blood test.
It may have saved several men's lives.
328 men showed up. Out of those 328 men, we found 56 of them had either severe urinary symptoms, or they had a raised PSA, or they had some other pathologies. And out of those 56 men, 9 of them turned up to have prostate cancer.
That's 1 out of 6 of the men with symptoms, and all were found early enough to treat. The evaluation team at King's College London recommended more clinics be set up to find out how best to reach men reluctant to go to their GPs.
Nothing's happened yet. There's lots of talk, but as yet, the hard cash is to be found.
I haven't got a clue why there's no prostate cancer screening in this country. I suspect that people are procrastinating in high places where these decisions are taken. There's a lot of administrative energy and cost associated with setting up a screening program, and if the basis of it is a PSA, then people are excusing themselves for not going ahead with this on the basis that it's not an optimal test.
NHS cancer screening is part of Public Health England. Julietta Patnick's in charge.
The National Screening Committee make these decisions. The money is not the issue at that stage. It's simply, should this screening programme happen or not? And the answer for prostate so far has been not. When that changes, when we have a better test, when we know how to treat the disease, then you make the financial case to ministers who make the final decision. But we're not there yet with prostate.
Fred and Gail don't know how much time they have left.
The tumours looks like they might have attacked the vertebrae of the spine, so I've got radiotherapy treatment to look forward to try and zap those and reduce the size of the tumours.
I didn't actually want to be given a time. I thought if somebody actually gave me an actual period of time, that I would feel I was being squashed into having to do these things that one naturally assumes that you have to do before you're not here. And I didn't want our 6 children between us to have this feeling that they had to be with us every minute of the day, that one day we weren't going to be here. I understand that. But it is so important for me that they live that they carry on living as children.
Three years ago, the bowel cancer screening programme was fully rolled out across England and Wales for everyone over 60. Ruth McDonough was in her 40s and so too young to qualify.
My name's Ruth. I'm 48 and I live on my own with my son. I've got bowel cancer.
For those who don't qualify for screening, it's NHS policy to leave the initial diagnosis of cancer to their GPs. That doesn't always work. Ruth saw hers a dozen times and was never told she might have cancer. She now spends a day in hospital every fortnight having chemotherapy.
I went to one GP and I'd experienced lots of bleeding. I was having lots of bloating and problems going to the toilet. She said I was too young, so not to worry, and I was given laxatives.
Shortly after, Ruth moved house and registered with another GP practice.
I went to see another doctor. Again, I was given a cocktail of laxatives, and that went on for a few weeks.
Ruth developed extreme abdominal pain and was referred to A&E, where she had an X-ray and other tests. She heard nothing further. Again, she went to her GP.
She said, you know, I think you just need laxatives and to take some warm baths and you know, try and get your tummy to go down.
Finally, another GP at the practice saw Ruth and referred her for blood tests, which led to her seeing a cancer specialist.
He said that I could come in that next day and he would do a colonoscopy, you know, put a camera in my bottom. And by then he'd been honest with me and said he believed that what we were looking at was bowel cancer.
In England, Wales and Northern Ireland, over 5,500 men and women under the screening age of 60 are diagnosed with bowel cancer each year, and many are in the late stages of the disease. The fact is, the NHS chose a screening programme it knew would miss many cancers and people would die as a result. The official evaluation determined that
it's the least effective of the screening options in terms of both survival and quality-adjusted survival.
So why offer screening only to people over 60?
At the time that we started the screening programme, we didn't have the capacity to do the entire country for a wide age group. So we chose to do 60 to 69 to start with, because that was the most effective age group to begin with.
Yet in other ways also, the screening programme they chose is second-rate.
Sitting in the morning sun, I'll be sitting when the evening comes.
San Francisco, California. This is the Mission District. In a wealthy city, it's where the poor struggle to survive. Yet they have a better bowel cancer screening programme than what's available on the NHS. It's run from San Francisco General Hospital, the city's so-called safety net hospital, and paid for out of public funds.
We see a large number of marginally housed or homeless patients, a large number of patients who have psychiatric illness, and then a large number of patients who are recent immigrants to the United States, and then also the working poor.
Screening here also starts with a fecal blood test. In England, it's for everyone over 60. In San Francisco, they start at 50.
If we were to increase the age to 60 years old, I think we would miss a large number of patients who might have these precancerous lesions or even colorectal cancer.
They also do the test yearly, rather than every 2 years, as in England.
We know that these lesions bleed off and on, and that's why we do it annually to try to detect them.
And they use a better blood test.
You have been invited to participate in the NHS Bowel Cancer Screening Programme. Using the kit involves collecting small samples from 3 bowel motions. You can do your bowel motion onto folded pieces of toilet paper.
The British test is called a guaiac test and looks for blood in your faeces. You have to collect 6 samples, 2 each from 3 different faeces, spread over no more than 2 weeks, and then mail them to a testing centre. In San Francisco, they use what's called the fecal immunochemical test, or FITS, which requires only 1 sample. It's easy to do, and it's much better at detecting cancer.
It's been shown in many studies that FIT test is much better than older guaiac test. Specifically, it can detect colon cancer at a higher rate. If someone has colon cancer and they do a FIT test, then over 90% of the time, a FIT test will detect it in that patient.
The Japanese screening programme has offered the FIT test to everyone over 40 since 1992. Today, the Australians, Italians and the South Koreans use it. It's also recommended by the European Union Cancer Guidelines. They all recommend screening begin at 50. The FIT test will be piloted in England from next year. But screening with a better blood test will lead to more positive results, requiring more bowel examinations called colonoscopies. And that's a problem for the NHS.
So first I do an external examination, make sure there's no abnormalities.
A colonoscopy uses a camera to look for sources of bleeding along the whole length of the colon.
So our goal is to just get to the end of the colon, and then on our way out is when we search for polyps.
Polyps are growths that can be harmless or can be cancers or become cancers.
As you can see, I found a polyp right there behind a bubble. Carefully. So this is our forceps. Open, please. Open.
They're going to snip off the polyp and send it to the lab.
Close. And we've got it. Go ahead, please, take the forceps. So you can see we got the polyp out. It's gone.
Here in San Francisco, the colonoscopies don't add to hospital costs because they have enough existing staff to do the procedures. But in England and Wales, there's already a shortage of resources to perform currently needed colonoscopies, let alone the additional ones the FIT test would require. Recently, the charity Bowel Cancer UK issued a report about inadequacies in the service.
We know that endoscopy capacity needs to double over the next 5 years, and yet we are very concerned that investment is not being made. That's going to lead to increase in deaths from the disease because patients will be diagnosed late. I think this situation's getting worse.
The issue is finding enough people and getting them trained, and it's not something that can be rushed. Endoscopy is a technique that has to be applied carefully, and it takes time to train these people.
So instead of lowering the age of screening to 50, the NHS has opted to offer what it calls a once-only bowel scope to everyone between the ages of 55 and 60. It's safer and cheaper than a colonoscopy. But it only looks at half of your large intestine, and will be available initially only in England, not Northern Ireland and Wales. We asked to film a bowel scope examination in England. The NHS screening spokesperson told us that we wouldn't be able to. He said that so far there are only a few small pilot schemes. And if we filmed and then broadcast nationally...
It's our concern that there'll be too much demand on the system.
Does this amount to a screening programme that's being done piecemeal and on the cheap?
Not at all. We have a coherent policy across the whole of England, delivered to a uniformly high standard across the whole of England, with improvements being made non-stop.
Nonetheless, there will be no screening for anyone between 50 and 54, about 1,500 of whom will get bowel cancer next year.
There are always people who get all the different cancers at ages outside the screening programmes.
And what can you say to them?
All I can say to them is that the NHS is there to deal with their symptoms. We get nearly 90% of people by looking at people over 60, and that will improve once we start offering FlexiSig at 55, which we're just beginning to do.
So they basically have to put up with it.
Currently, around a third of patients are diagnosed in the early stages of the disease, a third in the more advanced stages of the disease, and actually there's a third that we don't know anything about at all because the data is currently not good enough. But we do know that around 25% of patients are being diagnosed as emergency, and they generally don't have as positive outcomes to their treatment.
Ruth's local NHS trust recently admitted full liability on behalf of the local hospital for failing to refer Ruth for further tests and to inform her GP after it had discovered symptoms of possible cancer. Ruth's cancer is now in her spine and is terminal.
I wake up every day and I see my son, and I'm really grateful that I'm still here. Even if I know it's not going to last, I'm still around. I've got people that I'm friendly with that were diagnosed the same time as me and with the same stage, and that, you know, You're talking to them 1 minute and then they start to have a few problems, and within 3 months they're gone.
When you smoke, the chemicals you inhale cause mutations in your body. And mutations are how cancer starts.
Lung cancer kills over 34,000 of us each year. That's one death every 15 minutes. It's now the leading cause of cancer death in women. But there's no lung cancer screening programme.
I don't understand why the UK government is faltering.
So we've argued about the benefits of lung cancer screening for a decade now. We've really got absolutely nowhere in that discussion. There is no lung cancer screening programme in the UK. There isn't one.
Liverpool. It's one of the worst cities for lung cancer in Europe, with survival rates historically lower than in Naples, Italy, and Krakow, Poland.
My mum got diagnosed with lung cancer. She'd had a persistent cough for about 6 months. Originally, we thought it was because she gave up cigarettes, because she was a long-term smoker, my mum.
10 months later, she died.
My dad was diagnosed that he got the lung cancer, and then within 4 weeks he was gone, died. His father had it, and I think his brother had it, so it is in the family. And it puts fears in yourself in case you get it. So I've got a cough and it just makes you worried. I'm constantly worried now.
The notion that you can detect lung cancer in heavy smokers early is thought to be a bit of a myth. This is not true any longer.
David Baldwin is a leading lung cancer specialist and advises the government on lung cancer policy.
Lung cancer kills more people than breast and bowel cancer put together. The overs of lung cancer are going up year on year. So currently, about 1,000 extra patients are diagnosed with lung cancer each year.
And most are diagnosed too late to save their lives.
We get about 3/4 of patients that present to us at a late stage, which means they're at a stage where they can't receive or can't be eligible for curative treatment. And we know at that right at the beginning that we're not going to be able to cure them and that they've only got a few months to live.
A lung cancer operation at the European Institute of Oncology in Milan, Italy.
If I'm not able to feel it, I can just transect the part of the lung I presume to contain the nodule.
Here they believe if you find the cancer early, when it's small, it can be removed with minimal surgery and save the patient's life. The Institute's lung cancer survival rate is among the highest in Europe.
Now I'm trying to cut the portion of the lung containing the nodule.
The man who founded the Institute is Umberto Veronesi. 40 years ago, he proved that by finding breast cancer early and then removing only part of the breast, it was possible to save both the women's breasts and their lives. Today, they apply that philosophy to all cancers.
The new policy should be early detection, trying in any way to discover an early tumor, and they treat with a very limited surgery, because extensive surgery not only is not needed, but is, I think, only perhaps somewhat dangerous.
Back in the operating theatre, after removing the suspicious section of lung, they now look for the possible cancer.
I'm cutting this part of the lung to identify the nodule if inside. This here, you can see the difference between the normal lung in this part and the lesion here. Now we send this specimen for frozen section.
It turned out to be cancer, and a larger part of the patient's lung was removed. But the first step is to find the cancers early. And that's part of the problem. In Britain, we traditionally use X-rays. In Milan, they use computerized thermography, or CT scans. For them, it's a no-brainer, given their experience with X-rays.
The X-ray will detect 1 out of 7 lung cancer in the patient. And you will probably detect it when it's too late for the patient to be cured. Yes, this is a routine chest X-ray of a patient who is a heavy smoker and older than 50. And this is the typical person with a high risk for lung cancer. You can't see any lesion in the lung, parenchyma, while if you go to the CT scan, you see a lesion here that is clearly seen, and this is 1 centimeter lesion. It was operated and it was turned out to be lung cancer in early stage. And this is 4 years ago. Now the patient is well and in good habit.
NHS guidelines instruct GPs to send many patients, including those at high risk, off for an X-ray.
I really can't understand why you have to use X-ray, chest X-ray, for detecting lung cancer. This is an ordinary CT. It's a 10-year-old machine and is completely useful for low-dose screening for lung cancer. And nowadays, these machines are diffused all over the world, and it does not cost a lot of money.
Well, the X-rays are the thing that one might use as a tool to decide whether patients have a high probability of having lung cancer or low probability. So a patient that, say, has got a cough that's been persistent for several weeks, they might have a chest X-ray done by their GP. If that chest X-ray is abnormal, we then go on to refer them up to people like me who then do a CT scan. But if the chest X-ray is completely normal, then the GP then may decide not to refer the patient immediately, and often that's the right decision.
How are you feeling today, eating it?
Bit sick this morning when I got up. I had to take a tablet, anti-sickness, so hopefully that will do the trick.
Nick Pope never smoked, and today he has terminal lung cancer. He's a keen golfer and successful businessman.
There's my lovely wife, Sue, with Oscar on his first birthday. We're just at the start of the walk in Delamere Forest. Getting out of breath now, going up this incline.
Nick's trying to lead a normal life, but that's increasingly difficult.
Yesterday, didn't have a very good day, despite Oscar being one. We did a big walk, followed by a visit to the local, half a Guinness and a sandwich, and then I came back and didn't feel too good.
4 years ago, Nick was discovered to have a large cancer in his throat and one in his lung. Both were removed. He recovered well and was told to come back regularly for X-rays, which showed him to be symptom-free.
My experience has shown is that CT scans work on the lung, X-rays clearly don't. I would go back for a consultation every 6 weeks where they just took an X-ray of my lung and basically assured me that everything was fine. And I did say to my consultant, things aren't right, and all he did was an X-ray.
After nearly 2 years of this, Nick had a turn for the worse. He had 3.5 litres of fluid removed from his lungs and a CT scan.
And that revealed that the lung cancer had returned, and they also told me that my prognosis had become terminal because it had gone to the top of my spine.
Nick is now under the care of a different hospital.
In December, I underwent a couple of seizures. An MRI scan revealed that I had 87 tumours on both sides of the brain. My neurologist is very positive. Hopefully things will progress in the right direction. If it's anything to do with me, they certainly will.
Hi, I'm Nick's wife Sue, and I wanted to just put things from my perspective in terms of when you're living with somebody that's got cancer. I take my lead from Nick. He says I'm his rock. It doesn't always feel like that inside. But I know when I have to cope and deal with things. We've got options, and that's fantastic. If the chemotherapy treatment that Nick's on at the moment, if that stops working, then there's a trial drug, and so that's a real positive. What's tough is we're forced to confront things that perhaps we wouldn't want to talk about at this stage in our relationship. Death. Making a will. And Nick's funeral arrangements. It is tough, but that's what Nick needs to talk about, and I understand that. And I try and do my crying. When no one's around, so that I can be strong when we do need to have these conversations. I've experienced loving and being loved by a truly remarkable and inspirational man, and I couldn't ask for anything more in my life.
Lung cancer diagnosis is changing, but is England dragging its feet? The definitive study was done in the United States. It cost $250 million, lasted 8 years, and involved 54,000 heavy smokers. Half were given CT scans. The other half were screened with X-rays. 2 years ago, the results were published.
The study was set up so that we used what's called a low-dose helical CT. It goes around the body in a circle, kind of like a helix, goes all the way down from the neck down to the diaphragm. And it allows you to take very, very narrow slices through the lungs. We compared this with chest X-ray. And we found that individuals who were diagnosed with the chest X-ray had a survival rate of about 30% at 6 years.
Those who had CT scans had a survival rate of over 50%.
We were able to catch the cancers more frequently at what is called an early stage, when they can be removed surgically. We were able to do this enough that we lowered the chances of your dying from lung cancer by 20%.
So they stopped the study.
It would have been unethical to continue the trial at that point.
Why?
Because we felt that individuals who were in the chest X-ray arm should be informed that they should go out and have low-dose helical CT because it would work better in finding their lung cancers early.
It's been a game changer. American and French cancer specialist groups have called for CT screening for heavy smokers. In the US, if new official recommendations go into force, as they are likely to, Medicare will soon have to reimburse the costs of CT screening for high-risk smokers, and medical insurance companies will have to pay for it. But in England, they're waiting for the results of a small study of heavy smokers that compares the death rates of those who have CT scans with those to whom the trial gives neither CT scans nor X-rays. David Baldwin is the study's lead respiratory physician.
The original trial plan of this screening trial was for 32,000 patients to be split into two groups, CT scan and no CT scan, and then we would find out how much the mortality from lung cancer was improved during the trial. Unfortunately, at the moment, we don't think the full trial, which is the 32,000 patients, will be funded. But we've currently recruited all the patients into the pilot phase, which was 4,000, just over 4,000 patients, 4,200 now.
So you're doing a pilot study with 4,200 patients, half of whom will get no CT scanning at all.
We're doing the pilot study with 4,200 patients, half of whom won't get the CT scan at all.
It's going to take several years before the government has the results and decides how to act.
In the meantime, people potentially are dying of lung cancer because they haven't been screened.
And this includes the 2,100 volunteers in the trial who aren't scanned.
That's true. So what you're asking is, you're saying, is it ethical to run a trial at the moment where people aren't getting scanned? And that's a very, very important point. But at the moment, those people won't get scanned because there is no screening program in the UK.
You can't ask to me why the British are going on with the trial, offering nothing to a small amount of people if compared with the American one. We think is not ethical. If we have a trial like this here, after the American result, we would stop the trial and offer all the people the CT scan.
That's not what our ethics committees have said. It's got ethical approval. The American trial compared CT scanning with X-ray.
That's right.
Yeah, we're comparing CT scanning with usual care.
What's the point of that?
Because usual care is what we do now.
And you get 34,000 deaths a year.
There has recently been a campaign to encourage people to present to their GPs early.
David Baldwin and his colleagues have pointed out that participants in the UK trial who want CT scans can go private. They say that among the reasons they're continuing the study is to work out screening cost effectiveness and how to get heavy smokers to take part.
Often these patients that we try to recruit are quite difficult to get up to have these beneficial health measures out of their community, so that they are a hard to reach group.
This isn't a problem in Kentucky. Welcome to the smoking and lung cancer capital of the United States. You can't get a more hard-to-reach, hardcore, heavy smoking population than there is here.
This on tobacco store I come to. They keep my chew fresh, and I ain't got a big problem. I come in here, they have always got my chew.
We keep it good and fresh, so it's not sitting here going out of date.
Yeah, I can last me a day. Just a day chew.
I smoke Marlboro Lights at the beginning of the month, and then I smoke the Southern Steel Roll Your Owns.
A big bag of this tobacco will last her about 2 weeks.
2 weeks.
That'll last her about 2 weeks.
How much do you think you spend on you spend on tobacco a month?
A month? I say $100 or better. I don't smoke because everybody in my family's got asthma, bronchitis, emphysema, and all that. That's why I don't smoke.
Yeah, right.
That's why I took up chewing.
Yeah, sure. Have any of them ended up with lung cancer?
Yeah, I've got an uncle right now. He's got cancer from his head to his toes, and he's eat up cancer.
The local congressman, concerned that voters were dying of lung cancer, got some federal funds to run a trial. Tony Weaver was the lead investigator.
The goal was to try to determine if we could find high-risk people and use CT screening to pick up these lung cancers before they grew to a size where they were inoperable. This would be smokers, been smoking for 40 years or more, and they also had damage to their lungs. We selected those who had damage to their lungs by performing pulmonary function tests. Those that had the bad pulmonary function test, those are the ones that we picked.
I started smoking when I was about 12 years old, stealing cigarettes from my mom. And I smoked until I was 60. And I got up to 2 packs a day. And one day I come home from work, and in my mailbox was a pamphlet in there that said, have a free CAT scan if you're over 50 and you've smoked. And I thought, nobody gives a free CAT scan, so I just threw it away. So about a week later, I was over in my car smoking on break, and it come over the radio. You could have a free CAT scan and everything, so I thought, well. So about 2 or 3 days later, again in my mailbox, there was the same pamphlet, and I thought, well, somebody's trying to slap you in the face. Go down and get it done.
Linda had lung cancer.
Dr. Dixon come in the door and he says, Linda, you've just had your life saved. He says, we would not have found this on an x-ray until it was too late.
We found 254 people with lung damage. Now, out of that 254 people, we picked up 4 lung cancers with our CT screening, and all of them were at a stage where potentially they could be surgically removed.
That's a detection rate of 1 in 60.
You can get by with saving lives at a rate of 1 in 60 CT screenings. You think of how many tests we run in a hospital every day, and if every 60 tests somebody's life was saved, you would take that. You would absolutely take that.
If CT scans save lives, why doesn't the NHS have a national CT screening programme for those at high risk of lung cancer?
The big worry with CT screening is whether it is cost effective. If I had someone close to me who was at high risk of lung cancer, I would want to see them having a CT screen from the age of 60 onwards, at least every other year. They ought to be part of a screening programme, and the screening programme is in the gift of the government, not my gift.
Isn't this a question of England dragging its feet?
I think we're just very careful about what we do to our population. I'm very proud of our cancer screening programmes. I believe we offer the screening programmes that can hold their heads up against any in the world.
In the absence of comprehensive screening for lung and other killer cancers, the best thing you can do if you feel you're at high risk is to get your GP to refer you for the necessary tests to provide a confirmed diagnosis before you end up as an emergency admission to hospital, where your cancer is found when it's too late to save your life.
It's a blood test. It's not an expensive thing to do a blood test. And I still can't see the logic of not having a screening for prostate cancer.
I've got quite a few Twitter friends. In the last 3 months, 3 of them in their 30s have died of bowel cancer. The screening has got to be brought down to a much lower age, and it doesn't even involve going to the hospital. You do it in your own home. It's a kit that's sent through the post.
I would love to help people get screened and get scanned. That would, if I could just save one person's life, then it's all been worth doing.
We're still having far, far too many people being diagnosed late, and that invariably means that those individuals won't survive.